Yeah, so some of the things that we've done within the last 12 months, we've developed admission, discharge, and transfer criteria, because another thing we found with patient flow and throughput internally is that patients would stay in like step-down unit of care with a lower nurse-to-patient ratio because the physicians really just wanted that better nurse-to-patient ratio, but they didn't really need to be in that step-down level of care any longer. But there was nothing to hold them accountable that their patient really met floor criteria. So it was really physician to physician specific. So what we did as an organization with physicians involvement and nursing is developed admission and discharge transfer standards. So it's kind of like a clinical pathway. When your patient meets this, it's automatic that they will then be transferred to this level of care. And that applies to higher level of care and lower level of care. And that ensures that the patients get the right level of care that they need. And it allows us to have some accountability to really, nudge the physicians and say, Mrs. Jones can really go to the floor now. And this is why. And we actually also have a bed manager who reviews the charts to look at the clinical information and see when the patients meet that level of care. Because right now in most organizations, the charge nurses are the ones that look at that, and then they put in, they talk to the physicians and say, well, the patient really can go to the floor today. But there's no accountability, and the charge nurses can get busy and they don't have that time, or sometimes they don't feel empowered to have that conversation with the physician, and their focus really is to care for the patient. So we have a bed manager who is a very experienced nurse who actually is empowered to call the physician and have that conversation. And she has the criteria to back her up.